The primary endpoint of this study is invasive disease-free survival. That means how long they can survive without relapse at the local site, a distant site, at the same time of secondary breast cancer incidence in the same patient. And at the end, over at different time points like 3 years, 6 years, and 8 years, it has clearly shown the benefit around 3% of all the intended to treat population. But the subgroup analysis, out of all the 400 patients, the data clearly says that someone having node positive, that is, the disease already spread to the axilla, and this is the largest tumor size of more than 5 centimeter. These all population which we can stratify and can adapt to those patients with this data. We can give the dual drug to give the better results when they come for the adjuvant treatment. The summary slides says the same thing. This is the largest trial with robust uh, uh, planning for the with a lot of without any much bias, which has clearly shown that this IDFS benefit was seen in those patients who are node positive disease, and this became practice changing once you see the pathology report. And we know that these two drugs have to be combined, whether neoadjuvant or adjuvant or metastatic, for a better results rather than single drug, without compromising the efficacy, without compromising the side effects, excess side effects. And because the treatment is longer, that we have to, the patient has to take for at least 1 year, every 3 weekly. And IV infusions, especially those patients who underwent surgery, we cannot use one of the right upper limb or left upper limb for further IV cannulation. So this newer formulation, like subcutaneous formulation, can be replaced the IV formulation. These two drugs can combined and give once in 3 weeks as a subcutaneous form, whenever, especially when they are maintenance, which will definitely will reduce your clinic time and daycare time, and without affecting the efficacy, without much side effects. So this these two drugs like pertuzumab, trastuzumab, what we were discussing before, they coming as fixed dose combination for subcutaneous use. Whenever, especially they are combined with the hyaluronidase. Once you inject this injection into the subcutaneous plane, this hyaluronidase will dissolve the soft tissues and will we can give as much as 10 to 15 ml of the fluid subcutaneous without much discomfort to the patient. So to confirm the efficacy of this subcutaneous formulation compared to the regular standard IV formulation, there was a phase 3 non-inferiority study was conducted with different chemotherapy regimens, and with standard chemotherapy backbones. They have given these two drugs to half of the patients were randomized into given IV formulation, half of them was given a subcutaneous formulation. The primary endpoint to understand the drug levels at the end of the cycle 7, whether they are equal when if you give the intravenous or if you give the subcutaneous form, they found to be they are better in the subcutaneous form, and they have met the non-inferiority margin with better levels, better trough levels in a subcutaneous form. And side effects was comparable between the both two arms, and obviously someone getting in this a shot into the skin will have local skin reactions which are very minimal and manageable. So this Phesgo, that is coming as a combination injectable for to combine these two newer targeted therapies in a single shot, which we given at least over 15 minutes. That literally will reduce your daycare time to 3 hours to like 15 minutes in a daycare. That will save the patient's cost, hospital stay, and cross infection, especially. And we can administer these drugs at home as well. So that's it. That's the beauty of the medication. Over time, things will change. That medication can be, these medications without much issues the patient can administer at home, which will reduce the cost dramatically. This is the table which explains all these trials which I have discussed. And as of now, in HER2 positive early breast cancer patients who have tumor size more than 2 centimeter or were spread to the axilla, armpit, all patients should be subjected for the neoadjuvant therapy, as I mentioned, to address the micrometastasis, to get the pathological complete responses, which are indirectly, which will tell us that there are patients who got the better response if you combine two anti-HER2 drugs will live longer. So, thus I'll conclude my presentation.